Okay, so let's get started. Surgical management of IBD. So these are some of the key points I'm going to go over, all these different approaches and everything. So let's start with the clinical pearls in IBD surgery. And really the key thing is failing to prepare is preparing to fail in surgery. So you want to recognize failure of medications. That's number one. But it's very important to let them know the patient is not the failure. The medications are the failure, because some of them feel like, yeah, I failed this, I failed that, everything. I'm probably going to fail this too. No, it's not you. The medications were the failure. And surgery should not be the last resort, meaning they don't have to go through every medication and everything. And all the while they're getting sicker and sicker. We don't need to go through everything if we're not finding a medication that's working. And the other thing is quality of life is extremely important. And if they aren't getting a good quality of life, that in itself can be a reason to go to surgery. Recognize complications such as strictures, abscesses in Crohn's disease, toxic colitis or a cancer. You want to drain abscesses preoperatively with Crohn's disease, because we don't want to get in there and here we have an abscess and then it becomes sepsis and it's all over the surgical site. So we always want to reduce sepsis prior to surgery. Minimize corticosteroids, and I mean minimize. Like a lot of people think, do I have to be totally off steroids? No, but we want you as low as you can possibly get. If that's 10 or 15, but the lowest dose. And we want to optimize nutrition as much as possible in these patients as well. We want to help patients quit smoking. And we know this is difficult, but we should always be telling Crohn's patients to quit smoking, and even the UC patients if they are, because obviously this can be pneumonia, lung issues with, it's a surgical risk. So as much as possible, and we know it's hard for patients, but we want to get them smoking as little as possible to none. We want to improve their quality of life, and surgery can very much often do that. And we want to set postoperative expectations. Remember, surgery is not a cure in Crohn's disease. So they need to understand that. Bowel function sensations may be altered, thinking about if they have an ostomy, how their life is going to be different. Maybe their number of stools are going to increase. And what is recovery? They all want to know, how long will my recovery be and what will be my restrictions? And the other is postoperative monitoring, particularly in Crohn's disease, because we know that Crohn's can come back. So we need to discuss that with the patient prior to surgery, as well as after surgery when they come back, because they need to go back on therapy. Shared decision-making, extremely important. We need to engage the patient in this process, ask their preferences, timing of surgery, all these things, because once we engage them, they're going to go through surgery feeling better. It was their decision. They understood it was their decision and they wanted it. Often, if a patient goes to surgery and they're like, I don't want to do this. I don't want to, I don't want that. I don't want that. And guarantee you that afterwards, they're still going to be unhappy and they're at a higher risk for complications. So it's so important to engage them in the process. So ulcerative colitis, about 1/3 of patients will require surgery. And on the left there is the elective, failure of medical therapy. Steroid dependency, that's a reason to go to surgery as well. We don't want our patients steroid dependent. And believe me, this day and age, we still are seeing patients that come to us that have been on steroids for a year or more. And I'm like, where are these? What's going on here? I thought we educate patients. We don't want them steroid dependent. Complications, side effects of medications, dysplasia or cancer, if they have refractory EIMs, growth failure in your pediatric patients, and again, decreased quality of life is very important. Now, what are your urgent situations? If they're septic, have fulminant colitis, hemorrhage, colonic perforation, or toxic megacolon. So typically 2 or 3 surgeries are involved in ulcerative colitis. And between them, there may be a minimum of at least 3 months. We want to wait at least 3 months for the healing to occur and for scar tissue in there to soften. Now, you can go longer in situations. It's not like, oh, 3 months, that's it. Just depending upon the situation. But minimum, we like to have 3 months between surgeries. Often involves an ileostomy, can either be a permanent one, like a proctocolectomy, total colon removed and they have an end ileostomy, or they may get a temporary one if we're considering possibly doing a J pouch, then we may do a temporary ileostomy. But the entire colon and rectum is removed in almost all cases because that's where the disease is. And it's regardless of how much colon is diseased, because taking that all out, that is a cure. But there is a rare exception where we might do an ileorectal anastomosis, but I mean, this is extremely rare. But in maybe an elderly patient who has difficulty managing the stoma and just is like, no, then we might do an ileorectal anastomosis. But then monitoring is extremely key for that rectum because the colitis could come back there or a cancer. So very rare exception. J-pouch, not really for patients with Crohn's disease because Crohn's can come back. And one of our sayings is nothing like a pouch to bring out the Crohn's because you're holding stool and that microbiome, it changes that microbiome. But there is an exception. If they've never had small bowel Crohn's or no perianal disease, some will consider doing a J pouch in these patients. But I always say there's the caveat there, the Crohn's could come back. But that's more of a likely situation where they will have a little better results. Again, I showed you this before, the toxic megacolon, which this is right away when you see these patients, it is a definite consult to a surgeon immediately. And in those patients, when they have that, often, they're at such risk of perforation and everything that we may give them a diverting ileostomy. It's an alternative to an emergency colectomy in a setting of acute refractory colitis. The primary aim here is to avoid an urgent or emergent colectomy because they're too sick. And the secondary aim is maybe we need to decrease steroid dependence or bridge to medical therapy, improvement in enteral intake or nutritional status. Maybe nutritionally they were not good. And this can allow for an elective laparoscopic definitive procedure or colon salvage. So just by doing this diverting ileostomy. But I also want to bring out is that diverting ileostomy is often it's the most difficult stoma to manage. Often it is flush with the skin because it's just brought to the surface. Patients may have leaks, so a stoma therapist is so key in working with these patients to get that under control. They use convex appliances, all kinds of things to help that. The other key thing about this is in J-pouch patients, when they have a 3-stage, they have a temporary ileostomy at the 2nd stage to allow the pouch to heal. I always remind patients because later on, if something doesn't go well with that J pouch and they need to go back to an ileostomy, guess which stoma they remember? This one. The first one was an end, got a good seal, everything went well. This one, they had issues and they're like, I can't do that, I can't go back. And then I always preference, hey, let's look at which stoma was that. You did well with the first one. This one was the problem. So I always have to point that out. These are not good stomas to patients. They're not meant to be permanent. They're temporary. And here's the proctocolectomy with end ileostomy. Everything comes out, the colon, rectum, anus, and they have a permanent stoma. And here's it's called the Brook ileostomy, the end ileostomy. It's by Dr. Brook. And you can see how it is fashioned there. It actually is like a cuff, turning your sleeve over in a cuff and then attaching that to the body. The total abdominal colectomy with the Hartman's pouch, that means the rectum. Dr. Hartman was the surgeon who came up with this, but Hartman's pouch is the rectum and anus are still in place. With an ileostomy, and again, that means rectum is remaining. And this is often a staging procedure because this doesn't burn any bridges, meaning the entire colon comes out, they have an end ileostomy, but the rectum is left in place for later the possibility of maybe having a J pouch. And, that by leaving that rectum there, it's a placeholder. And I'm going to tell you, some patients who, once they have the ileostomy, they feel so much better. They got a great quality of life back that they say, you know what? I'm really happy with this. I don't want to go through more 2 steps of a surgery. This is fine. And that's okay. And believe it or not, we are seeing more patients that do say that, even young patients. They're like, I am happy with this. This is great. This is no problem. The thing there is the rectum would need to come out later on because that still could be a site where they could develop like a diversion proctitis from being diverted in there and have, discharges. They are going to have a rectal discharge with the rectum left in place because the mucus, forms in there and they're going to have to release it. Maybe once a day is usually the thing. But they could develop like a diversion proctitis that would need to be treated, or they could develop a cancer. So if the rectum would be left in place, you would want to surveillance that possibly at least a year. But otherwise, the rectum comes out and they keep the end ileostomy. Now here's the ileoanal J-pouch procedure. So here is that step that we just talked about. The colon's removed, rectum remains in place, and they have the end ileostomy. And so they say, okay, they want to move forward with the J-pouch. Here's the J-pouch. So you can see the rectum is removed. The end of the small bowel where that ileostomy is now fashioned into a J-pouch and attached to the anus. And that ileostomy is a temporary one. See, there's two pieces of bowel that are there. It's very flush with the skin. And then here's the final step where the ileostomy is closed. And again, this is 3 months between surgeries. And about a year or so ago, someone were like, why do we have to wait 3 months after we do the J-pouch? Can't we take that ileostomy down earlier? Well, guess what? They found out, no, they developed complications with leaks, with the anastomosis, full healing has to take place. And I tell the patients, this is safety. Doing these 3 steps and in this process makes it safe and having outcomes that are successful with a J-pouch. Here kind of shows you how it's formed. It's lapped over on itself on the left there and attached into the anus. And then you see on the right, there's you see that anal transition zone, that's about 1 to 2 centimeters of rectal mucosa that is left in place, and they do a stapled anastomosis. The reason being is if it's a little bit of a tight pull to bring, the small bowel down to the anus, because, we weren't built that way, but they can, work with the mesentery and stretch it down. If there is a tight stretch, leaving in this 1 to 2 centimeters can mean, hey, we can do the J-pouch. Otherwise, if it wouldn't reach, they couldn't do it and they'd be left with a permanent stoma. Now, the thing here is with that 1 to 2 centimeters left in place, that needs to be monitored periodically. When they do the pouchoscopy, they need to biopsy that area because it could develop into a cancer or dysplasia developing into that 1 to 2 centimeters. So we need to keep an eye on that. Some could possibly develop colitis back there and like an anusitis in that. And when they do, that is horrible. When they develop that, then we got to treat it again. Now, that's not common. Neither one of them are common, but they can occur. What some surgeons do and what we do at our institution is if a patient has a cancer or dysplasia in the colon, we will attach the J pouch down to the anus. We won't leave that 1 to 2 centimeters in. If we know it's going to reach, we will not leave that in because that will alleviate that risk. There's also the surgeons will still leave in that if they had no cancer or dysplasia develop in the rectum or the sigmoid. Then they will leave that in, and those patients have a lesser chance of developing a cancer down there. So 2 ways they do it. The other reason why they wanted to do the staple, because all patients were done hand-sewn to begin with, but they wanted to do the staple because in that 1 to 2 centimeters, sometimes there's that sensation of air, liquid versus stool, and they felt they could feel when stool was coming and, cinch so they wouldn't have a leak. But once we went to laparoscopic with the hand-sewn, I'm telling you, the hand-sewn, they aren't leaking. They aren't having those issues. Before the laparoscopic approach, they were having some leaks, and it would be maybe for 6 months, and then it would go away. But now with laparoscopic approach, they're not messing around with that area so much, and right off the bat, they're having good continence as well. So 2 approaches there. The stapled is also much easier for surgeons to do because it's just going around with a stapler versus a hand-sewn is pretty tedious. Benefits: technically a cure, eliminates colon cancer risk, get off all IBD meds, and that's extremely important to not have to be on those meds anymore. Restores health quickly, their anemia, nutrition, quality of life, restores bowel continuity through the anus, and they don't have to have a permanent stoma. And it may be done with minimally invasive techniques. And I would say pretty much they are all done that way: laparoscopic assisted, where they, may take the bowel out, they're forming the pouch. So some of it's laparoscopic, some of it's not. And then the robotic also in the going into the rectum that way. The bottom line is that rectal area down there where the anastomosis is, that is prime real estate. And you don't want to mess with that any more than you have to. Because every time you do something down there, do a procedure, you're causing scar tissue. And scar tissue can, don't have the flexibility of the tissue, can cause problems, obviously, when there's a lot of tissue down there. It messes with function. And it gives a better quality of life. And I can tell you about 90% of patients do feel that this does give them a better quality of life. What are the early things that can occur with UC surgery complications? Obviously, infection, bleeding, blood clots, dehydration with the stoma, and a post-op ileus. So we do all kinds of things ahead of time to try and prevent these complications from occurring. A good bowel prep, so they're cleaned out, antibiotics before surgery, and just during for a day or so. Blood clots, we put them on, blood, like heparin or anti-clotting meds. I can't even think of the name right now. It's really anti-clotting medications that they are on them for their duration while they are in the hospital. They stay on that. And then depending upon their risk factor, they may go home on them for a couple of weeks. But most of the time, our patients are fine just being on those meds while they're in the hospital. Dehydration is because of the stoma. They have to learn how to not just drink a lot of fluids. They have to eat first, then drink. Because obviously the transit time, they don't have a colon. If all they do is drink, it's flying right out of them and they're going to get dehydrated. So talking to them about how to eat, foods to eat to thicken their stool is very important. And the postoperative ileus, we don't see it often, but it's just that we start them eating and the intestine is like, hey, we're not ready for this yet, and it shuts down. So then we go back to starting all over with the clear liquids and go through a slower process, and usually they can tolerate eating fine. The rectum and anus removal with the proctocolectomy and with the J pouch, there's a risk of injury to ureters and nerves, which can affect their urinary flow as well as sexual function. Infertility could be an issue, or dyspareunia because of the scar tissue down there. It's firm and it can take 3 to 6 months. And usually that does resolve, even the urinary issue, as the healing occurs. And then the J pouch, that anastomotic leak down at the anastomosis. If that develops into a leak, they can develop a peripouch abscess. And if they're significant, we've had a few patients, for whatever reason, they kept developing a leak down there, even after redo, draining it and multiple things. And finally, we kind of said, you know, there's something there. They are just prone to developing those peripouch abscess, that it's not going to work. And we had to end up removing her pouch. It doesn't happen often, but it can for whatever reason, whether, you know, it was just being on excessive biologics and everything else, and it just didn't work. Late complications with the proctocolectomy, delayed perineal wound healing. That's a difficult area to heal because they're sitting a lot, so they got to do the side sitting. And it's just nurturing that area. I follow up with them and do things to try and help it heal. If it doesn't heal in 6 months' time, then the surgeon might have to go back in there and just refluff that, debride that tissue and start the healing all over again. Stoma complications that can occur, they can get a peristomal hernia, they can prolapse, sometimes they can get retractions that all involve revision of the stoma. And a small bowel obstruction. When that occurs, it's often due to adhesions. And I will see that sometimes with after a J pouch, and that area where we take down the J pouch, and that area there can be adhesions that develop there, and the bowel, you know, is always active, and it can just turn, and a section of bowel is being held by an adhesion, and it turns, it can cause an obstruction. And sometimes later on, they may have to go back and just release those adhesions if it becomes a real problem. J pouch, what are your issues? Pouchitis. That's just infection in the pouch that can occur. It's a change in the microbiome. It feels like ulcerative colitis all over again, and we treat it with antibiotics. Pouch function issues, that can be, like I said, that's prime real estate down there. If they've had multiple procedures, maybe they don't empty out as well. The pouch doesn't empty, or it may fall back. Sometimes it can prolapse back and they can't empty out well that way. So there's always issues. We have some that have to intubate and sort of do like an enema in order to get the pouch to empty out, and develop Crohn's in the J pouch. And that can happen. And it usually shows up above in the small bowel. So we're never 100% sure that they don't have Crohn's disease, but we try and make sure as much as possible before we do this procedure that we've ruled that out as much as we can. Because if once they develop Crohn's back in the pouch, look, they're back on the meds again. They're back on all these same issues. And I feel when that happens with a J pouch, we've totally defeated the purpose of what the J pouch is. And I go through and I tell patients, this is what a J pouch is meant to do for you. And when that fails, my thing is get it out, go back to an end stoma and you're done because we're not holding stool. And that's hard for some patients to understand, but I really stress that in the beginning. Here's the J-pouch complications. Pouchitis is 50% overall. Cuffitis, that's that little 1 to 2 centimeters of rectal mucosa we leave in. They could develop like colitis in that, very low percentage. Here's our anastomotic complications with leaks, the sepsis, very, low risk. Pouch fistula or sinus tracts, that can often develop off the anastomosis, where it just develops like a sinus tract. But if we can't solve that, that could end up in pouch failure as well. Anastomotic strictures, that's where the pouch is attached to the anus. They can develop a stricture there. Any anastomosis can always be a risk for a stricture developing. So we want to make sure that with that anastomotic stricture at the anal anastomosis, these patients need to get digital exams to make sure that that stays open. Dysplasia and neoplasia, very small. It's mostly in the cuff. And especially if it diagnosed previous pre-op diagnosis, they had dysplasia or cancer. Sexual dysfunction, I have there 15 to 50% because some people were reporting a lot. I've never seen that high of a percentage. Way in the beginning, I probably saw up to maybe a max of 35% of our patients. But I tell you what, I think the laparoscopic approach definitely reduced those issues because it's less manipulation of the tissue down in the perineum. Men, you may get impotence, decreased erections. Again, I see this improve in 3 to 6 months. If it does not, I would send them to a urologist, and hey, the little enhancement pills do work. But I usually see this improve. I don't see that being a lifelong problem. Unless the patient is older, they had problems before, you're not always going to change that with this surgery. Women, it's dyspareunia, pain on intercourse. And again, I feel that's due to adhesions. And they may feel that in the beginning, but again, as time heals, 3 months, 6 months, usually that goes away as the tissues heal and soften in there. If not, I send them to pelvic floor therapy. Female infertility, again, I don't see that as much anymore due to the laparoscopic approach as well. Crohn's disease, small percentage, usually develops later, and that can result in pouch failure. Pelvic vein thrombosis, very small percentage, but that could also result in pouch failure. So this is the most common, is the pouchitis. 50% of patients get them. It could be one episode or it could be more. The symptoms, like I said, are increased urgency. Feels like their typical thing is, I feel like I got ulcerative colitis all over again. Same symptoms. Etiology, reaction of the pouch lining to the microbiome flora. Acute pouchitis, usually a 2-week course of Cipro or Flagyl, takes care of it, and they usually tell me after 1 or 2 pills, they already see a difference. Chronic relapsing pouchitis is 10 to 15% of patients. We want to treat them. Sometimes it's a combination of doing Cipro and Flagyl that works. If they don't tolerate either of those antibiotics, Augmentin is also possible. Some may need long-term antibiotic suppression. Antibiotic refractory Crohn's, then they're back on budesonide, the biologics, Entyvio, etc. And there is a role of probiotics in preventing relapse, I feel. I do have some success with that. It's not always 100%, but it is the Visbiome that's the 900 billion bacteria in it that has to stay refrigerated. That is the one because it has the highest number of bacteria. And that's what you need in treating the pouchitis. And it doesn't happen right away. They have to stay on it and take it once daily. The problem is it's kind of expensive, unfortunately. But we need to get those probiotics as a medical therapy is what we need to work on doing. It also will help if a patient says they have a lot of gas and bloating all the time, even though they seem like they're I give them a probiotic and it seems to help with that. Here is my expectations for the J-pouch patients. And I tell them, I want you to take this, you frame it, you hang it up, and you look at this periodically, because when you deviate, you have to call me. Best of stool is 4 to 6. Usually pasty consistency. I want 80% of the time thickened stool in 24 hours. If not, they're going to get dehydrated if they're all loose. And plus their perianal area is going to be sore with all the liquid stools. They can usually delay a bowel movement up to an hour. I have some say 2 hours. Little or no urgency at all to pass stool. You will see that if they're developing pouchitis. Usually no leakage. If present at night, only a wetness. Older patients may be more at a risk for leaks and at bedtime, but most patients do not have leaks after a few months. Wet ones, moisture barrier ointments to prevent rash as needed because they're having a higher number of bowel movements. They can eventually eat most foods without difficulty. Spicy or high roughage may increase stools. Again, here, you have to eat first, then drink. If they just do all drinking, they're going to be all loose stools and multiple. So we want to be sure that, again, they're eating first and then drinking. Over time, that all does get better. And eventually, most patients say they don't have to monitor this so much. The other thing is they need long-term follow-up to remind them what is good pouch function. You want to assess for complications, monitor their blood work once a year, and a pouchoscopy. Because, again, pouchitis can sometimes be silent. Or on one scope, we may see just a little bit of inflammation. If they're on suture lines, that can be normal. But a little low-grade inflammation, it's something that I want to follow. And then, so that's why those patients would definitely need a pouchoscopy every year. If they haven't had any pouchitis, everything's going fine, maybe we go 2 years or 3 years. If they have a cuff left in place, remember that cuff has to be biopsied. So the key thing here is function improves over time, and it can be up to 2 years. So the first year, I follow these patients every 3 months, second year, every 6 months, and then I go on a yearly basis for a visit. Because what I found out, these patients, if they are not followed, they go back into that same colitis way of thinking as their stools are creeping up in number. And they're like, well, this is kind of just how it is. And I've had patients who didn't follow up. They kind of got lost. And then I get a call from them 2 years out. And of course, my first response is, where have you been? Because you know you're supposed to follow up with me. And they go, well, my wife and my mom told me I need to call you. And I'm, oh, what's going on? Well, I'm having 10, 15 bowel movements a day. And I'm like, you thought this was normal? Well, I don't know, and I've had it for 6 months to a year like that. And I'm like, oh my God, now it's going to take me longer to get this pouchitis under control. So it's key to get the pouchitis treated right away. And for him, I had to have him on antibiotics for probably 9 months to a year almost, and then I could get him off. And then since then, he's been fine. So the key point is getting them treated instantly. So let's go to Crohn's. When is surgery needed in Crohn's? Basically the same thing as with ulcerative colitis, but here we're going to have the fibrotic obstructing strictures, fistulas, abscesses develop, and the perianal complications. Typically, only segments of bowel affected are removed. Healthy bowel is always left intact. Mild disease may remain, like maybe they've got a stricture at the ileocolonic area, ileocecal area, and maybe they got some mild perianal disease. We're going to deal with just removing that stricture. We're not going to remove any more or get anything else as long as the medication works. Because remember, these patients can have, several surgeries if they develop Crohn's again, and then they could end up into short bowel. So only resect the stricture in that situation. Perianal abscess or fistula, ceton placement. Often it's a combination of medical and surgical treatment. Crohn's disease recurs at the same location over time. We find when we've done ileocecal resections, that's right where the Crohn's disease returns back. Exception to that rule in Crohn's disease, that's only in the colon, never had it in the small bowel or anywhere else. If we give them the end ileostomy, the colon, rectum, anus is removed, and they have the end ileostomy, sometimes that can be curative because there's no holding of stool. The ileostomy lets the flow right out. It was only in the colon, and sometimes it does not come back, but we need to surveillance them with a scope via the ileostomy, 6 to 12 months. You want to double check that it doesn't come back. Need to assess, like I said, for recurrence, even intestinal ultrasound, fecal calprotectin at 3 months, and then an ileocolonoscopy to 6 to 12, depends on their risk. Here are what strictures look like through a small bowel, through an MRE, a stricture video capsule, computed tomography. The arrows are pointing to all the strictures. The thing about the video capsule endoscopy, it better be a patency capsule that they throw down first that will disperse and dissolve. But believe me, we have removed several capsules that were not patency capsules that got stuck in there with a stricture. You have to use patency capsules in those situations. Resection of ileocecal Crohn's disease segment. These are the most common surgeries in Crohn's disease, is that ileocecal area there. Most common with the anastomosis. Sometimes a temporary ileostomy might be needed if in a situation that they had that ileocecal Crohn's, but then down in the sigmoid, they also have developed some Crohn's. And in that situation, high bacteria, we definitely want to do that. Here is stricturoplasty, which you may have seen. There's no bowel resected. Recurrence rates are very low in this type of a setting. We're just opening the area up. The key to know there is if they still have some inflammation left, they obviously have to get right back on therapy for that. But stricturoplasties work great. Here's a stricturoplasty of a patient who has a very long segment of strictures. What in that very long segment, I mean, you'd be causing them short bowel. What we do is cut that segment in half and overlap the bowel and open it up, and we don't decrease any bowel absorption capacity, and these patients do extremely well. Here are cetons. You see on the left, there's an abscess within the sphincters, and on the right, you see where a ceton is placed through there. It's to keep the abscess draining, get them on medical therapy, and once they're optimized, whether it's 2 to 3 months, the ceton can be removed if it's ability to. Here's that perianal Crohn's that's really bad. Here we've opened all these areas up and they get a stoma. It may be 6 months or more. I guarantee you almost all of these patients do not are able to get the stoma taken down because there's so much scar tissue. The anus area is so distorted that that's not an option, and they end up with a permanent stoma. And here's the proctocolectomy again with a permanent stoma. And like I said, in certain cases that could be. Here, I just want to kind of follow up with the side-to-side cono anastomosis. It was first used in 2003, and Dr. Kono came to our institution with Dr. Alessandro Ficara, who learned this process. And the intent is to hopefully it could prevent recurrence of Crohn's at that anastomic area. And this tells you at anastomosis, these are all the factors that are working there. The microbiome can change their fecal stasis because of the anastomosis and some stricturing there, cytokine production, or ischemia and innervation. So what can we do? These are all working in conjunction with each other. And we think that's why the Crohn's recurs back. Here's the cone OS. You see where the resection part is. And then in B, put those two ends of bowel back together. The mesentery is on the bottom now, so we're putting the two ends of bowel together. That becomes the supporting column. Look over at C, you've got the supporting column. Then we're making those horizontal incisions on each side, as you see them in D. And those are then brought together, and that supporting column stays there. It keeps the anastomosis open. and we have free flow going through that area. And here's the other issue, CONOS conventional, the blood vessels and nerve fibers all pretty much stay intact. We're not removing that. And that's the other issue in this area. So division of the mesentery preserves vascularity innervation, creation of the supporting column so that the anastomosis stays at that size and the anastomosis is wide, so there is less impeded flow. Is it safe? This is what results have shown so far, that it is. Very small risk here at all. And conclusion, Dr. Fakera says the best anastomosis, and if you've gone to DDW, you've gone to any of the surgical programs, you've probably seen him talk on this and presenting it. So benefits, removes the disease segment, significant improvement. Laparoscopic techniques are always usually can be done. Risk, again, all those major surgery things, but we do things to prevent it. Anastomotic leaks, of course, short gut with multiple surgeries, diarrhea stools, possible ostomy may be needed. Incontinence of stools, sometimes with the perianal procedures like setons or abscesses, they may have a mild. And always remember, surgery is not a cure. Postoperative recurrence is common. The most important piece for postoperative, follow-up in Crohn's disease, recurrence is clinically silent initially, as we've seen before. And here kind of gives you a timeline of how quickly Crohn's can come back. So postoperative recurrence, but here's the risk factors: early age, short time to first surgery, all of that. Cigarette smoking, if they have fistulizing disease, if they've had prior resections and perianal. So how do we prevent it? Medical therapy, prevent or limit the disease recurrence. Initiated post-op, they come back and they see me at the post-op visit. Right at that visit is where we get them started back. If there's no infections or anything, they get started right back on the medications. And the inpatient IBD APN comes and shares that visit with me. And her and I work in conjunction. But these patients all need to know about it beforehand as well. Always, again, engaging the patient. Discuss objective monitoring for recurrence after surgery. The fecal calprotectin, ileocolonoscopy, maybe it's 6 months. Communicate this plan preoperatively and postoperatively. And communication is key. And here's the summary, which I don't have to run through all of that.